I'm very, very happy today to be able to introduce Kaylee Rusin and Dr. Jennifer Mills for our webinar on the clinical implications of eating disorders in women with physical disabilities. Dr. Jennifer Mills is an associate professor in clinical psychology at York University and a registered psychologist in private practice in Toronto. She has 15 years of experience treating women with eating disorders, and she will use her clinical experience treating a woman with a physical disability and an eating disorder as the basis for the webinar. Her research centers around body image and eating disorders. And Kaylee Rusin is a senior doctoral student in clinical psychology at York University, working with Dr. Mills. Her dissertation, which she will be discussing in the webinar, examines the experiences of eating and weight management issues in women with physical disabilities. Kaylee uses her personal experience as a woman with a physical disability and as a disability advocate to help inform her research and clinical practice. Welcome to you both.
Thank you. Thanks. I just want to thank Jackie for that lovely introduction, and also thank you all for tuning in today. The way the presentation is set up is that I will start and introduce the topic, give you some background information, as well as some of the findings that are coming out in my dissertation. And then after that, Jennifer will follow it up with some of her clinical experience working with a client with a physical disability. And she will share some of her experiences and some of her strategies for effectively working with this population. So we're both very happy to be here today and happy that you're tuning in. I think when I originally developed this dissertation plan with Jennifer, one of the hopes was that we were going to be able to share this with other people and to spread some awareness. So I'm happy to be here. If you have any questions as I'm going through, feel free to type them up and we'll address them at the end. Or feel free to email either myself or Jennifer with any specific questions. If you want references for the research or you want to know about a specific scale, for example, I'd be happy to provide that information. So we'll just get started. I just would like to give you a little bit of background into this research project. I originally started graduate school working with Jennifer in the area of eating disorders and body image. And being a person with a physical disability and a wheelchair user, I tend to see the world through the disability lens. And because of that, I was kind of wondering, like, where are the people with physical disabilities in some of the places I was working at? Because I was getting feedback from a lot of other members of the disability community that this was an issue for them. They were having trouble maintaining their weight. They were going on diets. Some of them had eating disorders and did not know where to go for support. And I have a picture here of Sheena's Place, which is, for those of you outside of Toronto, is a really great resource for people with body image issues or eating issues. But unfortunately, it's in an old house, so it's not accessible for people who can't negotiate stairs. And this is not the only example of places that are not accessible for women with physical disabilities. So just sort of highlights that this is an area that has not been looked at very often, and it's an important area. And these women are sort of getting the short end of the stick because they're having the issues, but they're not getting the support. So I'll just start off by giving you a little bit of background into this area. This is a fairly new area of research, so there's not a ton of stuff out there. But what I did find when I started looking into the literature was that women who had a prior physical illness, so that could be defined as some sort of maybe physical disability, or maybe it could be like diabetes. So it was a very broad definition in the literature, that if they had that, they were at higher risk for developing an eating disorder, as well as disordered eating behaviors. So that can include anything from strict dieting, cutting your calories to a point where it's not for health reasons, but for trying to lose weight. Could be overeating or binge eating. So there's a very large spectrum of disordered eating behaviors, and eating disorders, of course, are on the far end of that spectrum, where you get people diagnosed with anorexia or bulimia, for example. And having a prior physical illness was actually a higher risk factor to developing an eating disorder than was having another mental illness. So, for example, we know that people with depression or anxiety are more likely to develop an eating disorder. But in fact, having a physical illness or a medical illness made that person at higher risk than having another mental illness. So it was a fairly predictable or predictive risk factor, which is kind of shocking given that there's not a lot of research on this area about what might be causing that. And also the type of physical illness didn't seem to matter. So this was across the board with things like cystic fibrosis, diabetes, women who were blind, spina bifida, cerebral palsy, scoliosis, multiple sclerosis, and rheumatoid arthritis. And there was some other ones in there as well. But just to give you an example of the type of physical illness that was impacting these women. So why would women with physical disabilities be at higher risk for developing eating problems? Well, as I said, there's not a lot of research on this area, but we can put together some of the smaller scale studies with a few women with physical disabilities, as well as what we know about eating disorders and what makes the person more at risk for developing an eating disorder. So, for example, people who have problems with early feeding as a baby, for example, or a child, if they had trouble eating, this is a risk factor to develop an eating disorder later in life. And we know that women with physical disabilities sometimes have problems with feeding, maybe because of the disability. There were some interesting studies that showed that if someone loses weight unintentionally, so maybe they get sick and they lose weight because of that, that can then spiral into disordered eating or eating disordered behaviors because they might get reinforced for that weight loss. They might want to keep it up and then start dieting afterwards. And probably one of the biggest physical risk factors is obesity and the pressure to lose weight. So we live in a society where it's not acceptable to be overweight and to be obese. So when you are obese, you have not only family and friends wanting you to lose weight and yourself, but also doctors who encourage you to lose weight. And we know that people with disabilities are 25% more likely to be obese versus 15% in the population of people without disabilities. And in some studies, over 50% of people with disabilities had major concerns regarding their weight and wanted to lose weight. So the more likely you are to want to lose weight, the more likely you are to engage in maybe unhealthy practices like dieting, strict dieting. And as I said before, a lot of these people interviewed, say with spina bifida or cerebral palsy, mentioned that the first time they started to lose weight, they were encouraged to do so by a healthcare professional. And although the healthcare professional had their health in mind and wanted them to be as healthy as possible, they were not so concerned that they were losing weight in an unhealthy manner. It wasn't followed up upon, and that person, those women later developed eating disorders. There's also a lot of psychosocial, social, and cultural risk factors. We know that persons with disabilities are also at higher risk for developing mental health issues for various reasons. Some people talked about having a physical disability was stressful, and they turned to caloric restriction to help manage that stress. The more they were counting their calories or focusing on food, the less they had to focus on their disability. Some of them talked about difficulties with peers, maybe being bullied as a child who were being overweight, or having difficulties with sexuality, like finding a partner or feeling like they were left out of the dating scene, for example. Persons with eating disorders often talk about their family being very enmeshed, very involved with each other. And we see that often with people with physical disabilities as well, maybe because of their disability, they might need a bit more attention, or maybe that's just the family style. So it's another risk factor that goes between the eating disorder world and the disability world. There's also, women with disabilities will often talk about having two different areas of pressure from society. One is the culture of thinness that all women have to struggle with, that thin bodies are preferable to fat bodies, and in order to maintain your standing in society, your social standing, you have to diet and look good and look like the women on the cover of the magazines. And then on top of that, women with disabilities will talk about being in a culture where able-bodied persons are preferred to disabled bodies. So they feel like they have sort of this double stigma going against them, that they have to be thin and they also have to appear less disabled. So some people, for example, might try to pass as being non-disabled in order to get past that stigma that's associated with having a disability. And we'll get into a little bit more about how this comes to play in my study later. So overall, I found there was a lot of lack of research in this area, and why that is, there could be a number of different reasons. One is that women with physical disabilities tend to underutilize preventative health care because of various reasons, lots of barriers, accessing doctors' offices, financial barriers, transportation barriers, the subway is not completely accessible. So there's for example, even though these women might be followed a lot by doctors, they might not be getting preventative health care, things like mammograms and pap smears and all those preventative measures that other people might take for granted. Another reason this might be a lack of research is that women with physical disabilities are often viewed as complex cases because they have a lot of different things going on. They have the disability, they have different medical complications associated with their disability, that sometimes when they go see a doctor, the disability is used to explain every other medical ailment that might come up. So they're losing weight. Well, maybe that's because of their disability. They don't focus as much on that person might be choosing to lose weight or trying to lose weight. And there might be manifestation differences between persons with disabilities and persons without. So for example, one of the common ways to diagnose an eating disorder is through body mass index, which basically takes the person's height and weight and determines whether they're in the underweight, normal, overweight, or obese category. But it's very difficult to take the body mass index of a person who might not have the same bone structure as a person who does not have a disability, or who has a low bone loss or muscle loss, or maybe they're short-statured. So there's a lot of different reasons why a person with a physical disability might not be diagnosed with an eating disorder. And finally, stigmatization theory. Some people believe that people with physical disabilities don't necessarily care about their appearances because they don't fit into that normal spectrum anyways. So if they can never reach that ideal beauty, why would they care to try to lose weight? So there's sort of just an assumption bias that they wouldn't have an eating disorder because they don't fit what we think of a person with an eating disorder would do. I'm going to talk very briefly about my study because I want you to know where this data is coming from. But I'm not going to go into too much detail just because I want to make sure we leave some time to talk about the clinical implications. So this is my dissertation. I wanted to look at women with physical disabilities and compare them to women without to see how at risk they might be to developing disordered eating or an eating disorder. So the first part of my study is 114 females who have a physical disability. And I gave them a bunch of surveys about eating, about body image, about their disability. And the second part was that I took 11 people from the first part of the study and interviewed them to find out how they think their disability has impacted their eating problems. So I picked specifically people who identified as, yes, eating is an issue for me, and I've struggled with an eating disorder in the past, or close to an eating disorder. So there were some people in my study who maybe they weren't diagnosed with an eating disorder, but they've certainly had struggles with it, and they either overeaten or have binge eating, or maybe they diet and they've been dieting their whole life. So I tried to get a range of individuals. These were the measures that I used. I won't go into details about what each specific measure is, but I just want to point out that I wanted to get a broad definition of disability because there's lots of different ways a person can be disabled. They can be disabled from their body medically. They can be disabled from the environment. For example, if they don't have transportation, then they can't access their school system, for example. They could feel disabled, or they can be functionally disabled, where they feel like they can't access the things they want. But they can also be diagnosed as disabled from a rehab professional. So again, tried to get a broad range there. I also put in a lot of scales measuring disordered eating, which we use in the eating disorder field. But because there's no scale that looks at disordered eating in women with physical disabilities, that was a little bit complicated, which was why I included the scales, but also wanted to include a qualitative portion of my study where I asked people, what was it like to participate in the study? Did you find the scales represented you accurately? And then I also wanted to capture body satisfaction, how satisfied they are with their body and their body image, as well as mental health, which might impact how they feel about themselves overall. So just to give you an idea, the sample, the range was 16 to 40. I had a range of different types of disabilities: neuromuscular disorders, cerebral palsy, spina bifida, spinal cord injury, arthritis, amputation. Most of the participants used a wheelchair, and most of them were disabled since birth. 60% of my sample felt that their disability moderately to significantly impacted their appearance. So that might be somebody who has, for example, scoliosis, and they feel like their spine is making their body look crooked. It could be other things as well, like amputation, which is a bit more of an obvious example of how your disability might impact your appearance. Approximately 21% said their disability was severe. And most people felt disabled in their life physically, meaning their body didn't work as well, as they felt like their body had a physical limitation in some way, or environmentally, meaning they couldn't access the environment as well as they would like. So that might be things like transportation or having stairs to access the places they want to access. And this is a rapid disability rating scale, which is something that rehab hospitals use to measure how disabled a person is before they're let out of the rehab hospital, or what services they might need. And my participants were rated as minimally disabled, which makes sense because my participants were active in the community. They weren't in rehab hospitals or nursing homes. So just to give you an example of how prevalent this is within the disability community, about 15% of my sample had an EAT score over 20. And that means that they would be screened out for possible eating disorder. And this was equal to persons without disabilities. So we don't know for sure if they had an eating disorder because that would take a lot more assessment, but 15% is a good number, is consistent with other research. 5.5% said that they engaged in binge purge behaviors in the past 4 weeks. So that might include eating a large amount of food and then throwing it up later, or using vomiting or laxatives to get rid of it. 29% said that they engaged in binge eating in the past 4 weeks. So that's quite a large number where people feel like they're eating a large amount of food in a very short period of time. In terms of BMI, about 17% met criteria for being underweight, 28% were overweight, and 13% were obese. Again, because a lot of my participants did not have access to weight scales that were accessible to them, I'm not sure how much weight I would put into these numbers, but just so you know. And 63% felt like they currently needed to lose weight, that was an important goal for them. Whereas 30% of those people were advised to lose weight by either a healthcare professional, and 48% were told to lose weight by their family. So overall, persons with disabilities had higher scores on measures of body dissatisfaction, anxiety, and they rated their health as poor. So persons with disabilities were more dissatisfied with how their body looked currently. They were more anxious, and they tended to rate their health as poor. Interestingly, the need to lose weight was equal across both persons with and without disabilities. But persons with disabilities tended to say things like, I need to lose weight so that my attendants continue to lift me, or I need to lose weight so that I can get rid of the pain that I have in my leg, and if I gain any more weight, I'll have more pain and I won't be able to go to school. So the reasons were very, very different, and I thought that was interesting to note. Similarly to persons without disabilities, the more dissatisfied you are with your body and the more invested you are in your appearance, meaning the more important your appearance is to you, the more likely you were to develop an eating disorder. But there were some interesting differences. So it seems like people with poor health tended to be more likely to develop an eating disorder as opposed to persons who were disabled or not. So that sort of makes sense that health issues might be more stressful, for example, than whether or not you have a disability. People who felt more disabled subjectively were more likely to develop an eating disorder, as opposed to objectively, where let's say a rehab professional might say, well, you can't walk, so you're more disabled than somebody who could walk. So that didn't seem to make a difference. And finally, the longer a person lived with their disability, the better off they seem to be doing in terms of less likely to have body image issues or mental health issues, which is interesting. So suggests there might be some coping going on. The qualitative research, which is ongoing, but seems to be very interesting and coming up with a lot of very interesting themes. Overall, what I seem to be finding is that persons with disabilities feel like they're sort of like an outlier or an other. They don't fit into the normal idea of what it means to go on a diet. Then when they try to go see a doctor, they feel like they're always the first person that has that issue and that the doctor's stumbling to help them. And even though they feel different, every one of my participants are trying to find their own normal, what that means to have a normal life for them. But for every participant, disabilities seem to be a very large part in the development and maintenance of their disordered eating, how they manage their weight, and how they feel about their body. Although disability was important for everybody, it tended to change for everybody on how important and in what ways it impacted. So I was really happy to do the qualitative piece because it got such variable and complex information. But at the same time, we're not going to be able to say that all people with disabilities find this because it just doesn't exist. These are some of the emerging themes that have been coming up in my research that I'd like to touch on a few of them. The first is the multi-purpose function of food. So people use food for a lot of different reasons, both with and without disabilities. But for people with disabilities, there might be a lot of different reasons, such as I use food to bond with other people. This is something accessible that I can do. I use food as a distraction from my life. I use food when I'm bored. The second theme, compensation, I found really interesting. So almost every participant acknowledged this as something that they do, where they know that disability is something that socially is not welcome in our society. To be a disabled person is not as easy as being an able-bodied person. That's sort of the message that society sends us. And some people feel that, and then they try to compensate. So they do things like say, well, because I have a disability, I have a few skills notches down on that end. So I'm going to try to pump myself up in this area. I'm going to try to be really smart. I'm going to look really good so that that makes up for the perceived limitation on this side. And that's where control comes from too, the third theme that I talk about. So a lot of people will talk about their disability being very chaotic or difficult to predict. But food and their appearance is something that they can control. So they would put their energies into areas that they can control, and that somehow makes it feel better that they can't control other areas of their life. That also goes in terms of the next one, undesirable obesity. So we know that in our society, being obese is not acceptable. It's undesirable. People don't want to be obese. And people with disabilities get this message sometimes even harder than people without. So they might say something like, I don't want to be overweight because then I'm going to be disabled and overweight. And a few of my participants called them, they said they didn't want to be like the fat disabled girl, which is a very powerful statement and very negative. And that they didn't want to, they already were seeing being perceived as negative in one sense, so they didn't want to be perceived as negative in another sense of being overweight. They also felt like people would judge them and think that they put themselves in the wheelchair by eating so much, for example. As well as obesity was seen as negative, especially in health-wise. So people are perceived as, well, if I get too big, I might not be able to get out of my wheelchair, or who's going to help lift me? So there's also the mobility aspect of wanting to stay away from obesity because it might make me more disabled. The next one is seeking accessible and knowledgeable support. That was a common theme, and it was something that was very difficult for people with disabilities to find support that was both knowledgeable about their specific situation and accessible. And they would often talk about making it up as they go. So if the healthcare professionals don't know how much weight I have to lose or how much calories I should eat, then I'm just going to pick a number. So a lot of people would say, well, I eat 800 calories a day. And I'd say, where did that come from? And they say, my doctor says you need to eat 1,000 calories a day. And I figured, well, standing people need to eat that much, then I need to eat this much. So a lot of doing their own doctoring, if you want to call it that. Dependency, people with disabilities have to depend on a lot of people, and I think Jen will get into more details about what that means, especially with attendants who are getting the person's food, getting the person up in the morning, getting their clothes on. They also feel like it's an ongoing, like I can't take a minute because I'll gain weight, and I always have to be paying attention to my calories because I'm a person without a disability. And barriers, which were very common, both financially, in the environment, in terms of how people perceive them. And finally, there was a lot of resistance and resilience in this community, which maybe explain why, even though they feel less satisfied with their bodies, they seem to be not necessarily getting eating disorders at a rate we would expect them to. So there's definitely some resistance going on, and a lot of coping and a lot of getting over perceived difficulties. So on that note, I'm going to turn it over to Jennifer, and she's going to continue and talk about the clinical implications of what I've just been talking about.
All right, so first of all, let me say thank you to Jackie and to Nedic for organizing this webinar today. And I'm really happy to have been asked by Kaylee to contribute to part of the presentation. My interest in women with both a physical disability and an eating disorder I received a referral in my private practice from another psychologist who had a patient who was in need of specialized treatment for an eating disorder. And this patient had been in psychotherapy before, but had not received treatment for her eating. And I'll present some of the information about this case of Carol. Carol is not her real name, and some of the details of the case have been changed to protect her privacy. But I also think Carol for sharing her story and allowing me to discuss her experiences with you today. So Carol has cerebral palsy, which results in spastic quadriplegia for her, and she requires a wheelchair all of the. She lives alone in Toronto, and she has 24 attendant care. And it's been a learning curve for me personally to learn about the barriers as well as the resources for people with physical disabilities. And I've gotten to know about how services like Wheel-Trans and attendant care work, which was something that I didn't know very much about to begin with. At the time of the referral, Carol met criteria for a diagnosis of anorexia nervosa, binge purge subtype. And she had had the disorder for over 10 years, which is quite significant. Her doctors had largely ignored the fact that she hadn't grown much during adolescence when her eating disorder started. And that was in part because they didn't know what to expect in terms of height or weight. And Kaylee touched on this earlier too, that body compositions can be different in people with physical disabilities. Carol recalls that at age 18, after she had had anorexia nervosa for several years, she was told by her doctor, "You're very underweight. Make sure that you're getting enough assistance at mealtime." And that was the extent of her doctor's concern about her weight. And this is something that other persons with these report, that their psychological well-being can sometimes be overlooked by their medical practitioners. So Carol's BMI was extremely low when I first started seeing her 4 years ago. And I had some serious concerns about seeing her just on an outpatient weekly basis. But Carol did not want to, and in fact didn't think that she could even go to an intensive hospital program because of issues with accessibility. I checked with her family doctor to ensure that she was medically stable, and I actually shared with her GP the medical management guidelines that are published by the Academy for Eating Disorders. This is a great resource if any of you listening today are interested in accessing those. It's the Academy for Eating Disorders that publishes medical management guidelines. And because there are problems with using BMI or body mass index as a gauge for health, this is especially true with certain illnesses that can result in a physical disability. And this means that it's even more important to get blood work and EKGs done on a regular basis. So in the end, I felt reasonably assured that it wouldn't be irresponsible of me to see her on an outpatient basis, and she agreed that she would need to gain weight. And when we started treatment, she agreed to increase her eating from about 200 to 300 calories per day to approximately 900 per day. So it was quite a large commitment for her to make, which was great. And as is common in the treatment of anorexia nervosa in any individuals, during weight restoration, she did experience very strong urges to binge, and those gradually tapered off. My approach to psychotherapy was cognitive behavior therapy as well as client-centered motivational enhancement. And Carol has done extremely well in her recovery. Her BMI has now been stable between 18 and 19 for the past year and a half. She still has some restrictive eating, but overall her health and her quality of life have both been really significantly improved because of her journey through recovery. I want to talk about some really interesting and important clinical challenges in treating people with physical disabilities and an eating disorder. Some of these dovetail quite nicely with what Kaylee was talking about earlier and her emerging results from her research program. It can be a real challenge to develop rapport and to convey understanding. Persons with disabilities and eating disorders are sometimes very skeptical about being understood. And part of that may be the eating disorder, and part of that can be compounded by a history of feeling marginalized or feeling like an outsider. There are serious medical complications and physical limitations rather, with certain chronic illnesses, and then of course the eating disorders themselves. So in the case of Carol, for example, she takes prescribed laxatives because of her physical disability. However, she was also engaging in laxative abuse as part of her eating disorder. And so it was important for me to communicate with her and her doctor about which medications were necessary and which ones were not necessary and could actually be doing more harm than good. So the use of strong products, enemas, clean prep, those kinds of things, those are warning signs. And through the journey of recovery, I think an individual can come to have better insight into the fact that the use of those things cannot be justified by the eating disorder, that those are part of the eating disorder, and the need and the desire to use products like that has to be targeted as a symptom of the eating disorder. Another clinical challenge is attendance services, and Kaylee touched on this briefly. This was very important in the case of Carol, and I came to understand for her just how triggering some of the attendance that she had around her could be. At the height of her illness, Carol spoke about how she was very much triggered by comments of her attendants, some of whom have a low education, some of them have a very poor understanding of eating disorders, but verbal comments about the fact that someone is heavier, or comments about the fact that a person's clothes are fitting them tighter or are harder to put on. Even if the comment is ambiguous, it can be interpreted as being indicative of weight gain, which can be, of course, very distressing for someone with an eating disorder. At the same time, attendance can be used for reassurance seeking. So that's another kind of special manifestation of the eating disorder that has to be targeted in treatments. And encouraging the client to not use attendance as a way to reassure themselves that they don't look like they're gaining weight or that they're still very thin. And of course, access issues come up. So whether it's low finances or inaccessible locations, transit difficulties, difficulty in finding employment, these are all things that, as a therapist, I suppose you have to be prepared to talk about in therapy if they are relevant for the client's case. Going to a hospital disorder program, for example, can be very, very difficult because of the need to drink enough water for some individuals with physical disabilities, and that would be frowned upon or maybe even prohibited in a group setting where everybody has to abide by certain rules and policies. It can also be difficult to get attendant care while you're in a hospital treatment program, and just the logistics of arranging for an attendant to help with using the bathroom. Some places are not wheelchair accessible still, so that's another challenge. I'm going to talk about some general strategies now for effectively working with patients with physical disabilities. And when I wrote these up, I had both therapists and clients in mind. So I can see that some of you are having trouble with the audio. So I'm going to speak up a little bit louder, and hopefully that'll help. So these are pointers that I have found helpful in my own work with a client with a physical disability and an eating disorder. One thing to think about is to explore your own assumptions and your own biases about the notion of disability. So do you see disability as a flaw or a limitation? Do you see it as something negative? And I think it's really important as a therapist, it's incumbent upon us to do that kind of self-reflection and to examine our own attitudes and beliefs. Except when you don't know something, and never assume something about the client. This is especially important with something like a physical disability that you as a therapist may have absolutely no experience with. But be willing to do some research and talk to the client about what you know and what you don't know, and how you can maybe get to know the things that you don't know a little bit better so that you can be more effective. Be creative and be flexible when you're collaborating on behavioral experiments. So, for example, if there's an experiment to eat out and to do a type of exposure to a restaurant meal, collaborate with the client. Clients, especially if they've been living with a physical disability for a long period of time, they may have some great ideas, and they may be able to think outside the box in some really creative ways, and so you can use their own resources to help be a bit more flexible with behavioral experiments. I think it's really important to balance between accepting the disability and its limitations and pushing for change. As we all know, all of us who work in this field, ambivalence and resistance to change is part of the eating disorder. And so as a therapist, we often find ourselves pushing for change in a gentle way. So know what the limitations of the physical disability are, but don't let that stop you from pushing for change and challenging the client to do certain things. Don't just accept the fact that he or she may be using laxatives on a very, very frequent basis, let's say. Do your research, find out whether that's absolutely necessary, and then push them to consider not doing that as often. So another way of looking at this is the balance of acceptance and normalization. Be willing to challenge the client and those eating disorder beliefs. So this relates to the earlier point so much insofar as a client may think that they only need, say, 500 calories to maintain a healthy weight. There are lots of myths that exist around how many calories people need. And so there are these numbers that people get in their heads. So someone with a physical disability might think, well, because I'm in a wheelchair, I don't need as many calories, or because I do this, I don't need as many calories. Don't underestimate the power of the eating disorder. The eating disorder thoughts can be so strong and so pervasive that they can justify the eating disordered behavior any way they want. And particularly if family and friends are pressuring them to change, it's again incumbent upon the therapist to be that voice that isn't afraid to push for change in a way that again respects where they're at in terms of their road to recovery, but you have to be willing to challenge those eating disordered beliefs and not be afraid or anxious to do so. Use the client's resourcefulness to your advantage. Again, the idea of different kinds of outings that can be tailored to the capabilities of the client, ways in which they need to overcome things in their lives. Many people with physical disabilities are already doing this, and you get to know a person's personal values and their personal strengths through asking them. Ask them what kinds of things they want to do. I know that for some individuals with a physical disability, eating out in restaurants can be a really enjoyable and important social value because it's something that they can do with groups of friends that their physical disability doesn't necessarily stand in the way of. So get to know the kinds of things that are important for your client and then use that to help motivate them to overcome the eating disorder. Be willing to advocate on the part of the client. We can't always expect clients to advocate for themselves, and sometimes we have to step up and do so. So if you're working in a work setting that isn't accessible, or if there are other barriers, physical or otherwise, that prevent the client from getting the treatment that they need, you must be able to stand up and advocate for your client. Willing to work with other healthcare professionals is something that, again, in my own experience, I found very, very helpful, both as a source of reassurance and a way to increase my own knowledge base about physical disabilities. So with the client's consent, make sure that you're able to communicate with other healthcare professionals, whether it be internal medicine specialists, family doctors, dietitians, and then make sure that you're all on the same page. And last but not least, ask the patient or the client how to best accommodate their needs. Ask the client directly what you can do to help them access the office, or what you can do to help them to be able to complete some homework assignments. And then on reflecting and putting together this presentation today and speaking to the client whose case I presented, one of the things that she talked about was the fact that if you tape recorded our sessions, most of the time you wouldn't know that Carol is in a wheelchair or that Carol has cerebral palsy. And she expressed to me just how satisfying that is for her. I think at the same time, it's really important to not ignore the disability. And sometimes as a therapist, your own anxiety might push you to try to avoid conversations about the disability. So it's a really tricky balance, but if you have good communication with the client, and if you have an open mind and are willing to do some additional research, you can strike a good balance that meets that individual's needs in terms of acknowledging the disability, but also not letting it overshadow everything else. Not everything has to do with the physical disability. There are personality factors at play. There's social factors at play. There are family factors at play. So, in summary, my experience in working with a woman with both cerebral palsy and anorexia nervosa has shown me that the nature of the illness is very, very similar to persons without a physical disability. However, the expression of the illness can be different. And in some people with physical disabilities, there are additional clinical challenges that make recovery even more difficult. So my advice to therapists is to be ready for seeing a client with a physical disability. If you're working in private practice or if you're working in a hospital or a clinic setting, chances are at some point you're going to have a client approach you for treatment who has a physical disability. Be ready for that. Think about your physical space, work through your own barriers, whether they be your own anxiety or your lack of knowledge or even just your inertia. For the longest time, I had a waiting room that was quite tightly decorated with chairs, and I had known that if I had a client with a wheelchair, it might be difficult for them to get in. But because of inertia, I didn't really do anything about it until the situation presented itself. But if a client approaches you for treatment and if you don't express and convey confidence that you're comfortable in working with someone with a physical disability, then that can be off-putting to them. And they may not even make an appointment with you if they sense that you're not confident and prepared for that kind of working relationship. For individuals struggling with an eating disorder, I encourage you to tell your therapist what you need and what you want, and to look for someone with whom you feel comfortable. If you decide against a program or a therapist for a reason, please work at feeling comfortable at politely telling them why, so that they have that feedback and they have an opportunity to address it in the future. So on that note, I'm going to give it back to Kaylee for some final words and future directions.
Hey, thank you, Jen. Yeah, I'm just going to touch on where I think we should go from here. I really liked Jen's approach to working with this client, and I just want to touch on one of the things that I find is so important is that when I looked at my research, a lot of the clients, every single client was at a different stage of acceptance and about how prevalent the disability was in their life. So that striking the balance between accepting the disability and talking about it, but not overshadowing that everything has to be about the disability is so important, I think, because some clients, the disability, maybe they don't even identify as a person with a disability. They don't feel like that's important to them. And I can even look at my own journey of early on in my disability, I probably wouldn't respond very well to a therapist that talked about my disability. But now I would feel like it's weird if they didn't talk about my disability. So it just shows that you really need to be flexible as a therapist and meet the client where they're at. I think that this research really touches upon that more training is needed for healthcare providers. That includes doctors, nurses, and dietitians. A lot of my clients are struggling. I mean, a lot of the people that participated in my research were struggling with this, but most of them didn't receive support for it. And the reasons were long and varied, but a lot of them included feeling misunderstood, feeling like they can't access it, or even if they did, they wouldn't be able to help them. So I feel like we need to really shift that culture of persons with disabilities feeling like they're on their own. And to do that, I think that requires a lot of training and a lot of attitude shift, as well as personal support workers. How do we train personal support workers to be more sensitive to persons who might be struggling with their body or with their eating? And as well, you want, as a healthcare professional, you want to have a knowledge of supports. You don't want to go see a therapist and have your therapist be like, oh, I don't know where people with disabilities go to get attendance services. I can't help you with that. Or what do you mean the subway's not accessible? I don't understand. So you don't want to be that healthcare professional, because that person's going to get turned off and not want to see you. Oops. And more research is needed, because as I say, I think my study is one of the first that actually looks at a large scale population of persons with disabilities. There's literally nothing out there to help persons with disabilities when they do want to manage their weight. They're sort of just left to their own devices. How much calories should they be eating? What should their BMI be at? And if that doesn't work, then how can we develop new standards to help them, guide them, so that they're not resorting to their own 600 calorie a day diet that could be unhealthy and unsafe. And this research needs to involve persons with disabilities, get their feedback. And I think that it's really important to use qualitative inquiry as well as traditional methods, because most of these scales that we're using now for research were not developed with persons with disabilities in mind, and they might not even be valid for this population. So we really need to be flexible and creative with our research as well as our clinical practice. And finally, barriers came up both in the clinical practice with the work with Carol that Jen's doing, as well as in my research. We really need to work on some advocacy efforts to make our environment more accessible, so that persons with disabilities don't feel like they're always struggling with this uphill battle. So things like the Accessibility for Ontarians with Disabilities Act, which is coming into play in the year 2025, which is supposed to make everything accessible, and that would be great. And things like storefronts and schools and hospitals, we have a long way to go to making them more accessible, so that people feel welcome and so that they can use the services. Economic disadvantage, so things like helping persons with disabilities access schooling, access jobs, so that they can contribute in a way that feels meaningful for them. Accessible transportation is so key, because if you can't get out of your apartment, you really don't have a strong quality of life. As well as supports to live independently. We want people with physical disabilities to be a part of the community, to contribute, to feel like their life is meaningful and enjoyable. And to do that, they need to be able to have the support so that they can live on their own. And that includes accessible supports for all types of things, treatment centers, whether it be a hospital program, or, like Sheena's place, a more community-based treatment center where people can go and meet other people struggling with the same issues as them. As well as recreational activities. So there's not a lot of accessible exercise equipment, for example, in the city of Toronto. So it becomes more difficult to manage their weight, so that's when they turn to things like dieting, as opposed to more healthy, balanced ways to manage your weight. And preventative health care, so that it's not just, let's just react when this person gets sick and help them. Let's try to see what we can do so that the person develops healthy attitudes towards their weight and towards eating before they develop an eating disorder. And finally, we really need to shift our attitude towards persons with disabilities. A lot of the issues that were coming up with my participants were created by a poor attitude towards people with disabilities, people who are overweight. And these are things that can be easily circumvented, but it takes time and culture change. So on that note, I just want to thank you all for joining in. I have my email, as well as Jen's email, and the NEDEC website. And please feel free to email us with any questions, or if you want any more information. We have some questions that we're going to address as well, but before we do that, I just want to acknowledge all the people that made this talk possible. The volunteers, Iris and Olivia, my committee members, as well as all the women who bravely and openly shared their experiences. So thank you.
Thank you so much, Kaylee and Jen, for being here. On behalf of everyone at NEDEC, we're thrilled to have you here. You're speaking to the need for more research. You're speaking to the need for sensitivity, for training, for challenging body-based stigma and discrimination in a way that is innovative for NEDEC. And so we're just so thrilled to have this opportunity to have you here. And you're contributing to that new research, right? I mean, it's fabulous to hear, Kaylee, about what you've been doing in your dissertation, Jen, the case study is just, I'll speak for people in the chat room and imagine that it's been very helpful to kind of see the theory and the practice come together there. A few questions did come in via email, which I hope that we've been able to address some of those. I'm just going to look in the chat box here to see if we've got more questions coming in. Looks like we have a past student in the room. Hi, Madeline.
Hi, Madeline.
Does anyone have any additional questions while we have these two captive for another few minutes? Please feel free to write it in the chat room there. And of course, we can always address questions via email afterward. I know that one of the questions that came in over email was whether Kaylee and Jennifer would recommend any particular books or websites for people working with these populations. I wonder if either of you could speak to that at all, if you have any recommendations, clinical or otherwise.
Yeah, sure. So there's actually nothing that I'm aware of that is physical disabilities and eating disorders simultaneously. Of all of the treatment resources and self-help books I've ever seen on eating disorders, I've never seen anything, even a chapter related to physical disabilities. So there's a real gap there. In terms of eating disorder resources on their own, of course, the NEDIC website is wonderful and includes lists of other resources, books, for example, or other websites. I mentioned the Academy for Eating Disorders is my go-to place for medical management guidelines. In terms of self-help books, Christopher Fairbairn's Overcoming Binge Eating is a classic, one that I also go to. And the Overcoming series, Overcoming Bulimia Workbook, Overcoming Anorexia Workbook, those are both very helpful, either for someone to work on their own or as an adjunct to psychotherapy. And Kaylee, do you want to speak to anything specific to disabilities?
Sure. As Jen said, there's not a lot out there specifically related to eating and disability, but there are a few great disability psychotherapy books that I've consulted in the past. Dr. Rhoda Olkin is a psychologist who also identifies as a woman with a disability and has written about her experiences being a psychotherapist. So there's a couple that she's written about the disability affirmative model, which really touches on that idea that we were talking about not overemphasizing the disability, but also not underemphasizing it, so striking that delicate balance. So if you look up Dr. Rhoda Olkin, you can find a lot of great stuff written by her. In terms of websites, I think if you're a person with a disability in Toronto, you're probably familiar with this, but the SILT website is really great. Center for Independent Living Toronto, they have a lot of great resources, as well as access to various supports like attendance services and direct funding. And also the DUN website is great as well for specific disabilities.
Fabulous. Actually, there's one more question that's come in for Kaylee here, and this is about critical disability feminist theory. Is this going to be at play, do you think, in the recommendations coming out of your research? And wonder if that's something that you could speak to at all.
Yeah, I mean, I think that right now I'm in the stage where I'm still putting together the results and trying to explain what they mean. So I definitely feel like looking into the critical disability feminist theory will be a key part to writing up what these results mean and how to explain them. I've been looking a lot into the critical disability framework, a little bit less into feminist, more feminist and eating disorders. I haven't found a lot linking disability and feminist theory, but I've been looking at the two separately, and I think that it's going to be really interesting to put it all together. So I'm looking forward to that.
Well, I know we are too, and I know that we will be watching you, both of you, in the future as we go forward. Thank you again to everyone for joining us. Thank you so much to Kaylee and Jennifer. Please stay in touch via email and definitely stay tuned for our next webinar. We've got some interesting ones coming up this year for you. Thanks very much, everyone. Have a great day.